Now the next speaker, may I request the next speaker, Dr. Dinesh Chinchure. He is having two topics. One is bowel and mesenteric injury on trauma CT, and the second topic is MRI in rectal cancer.
Dr. Dinesh Chinchure holds the teaching post of Clinical Senior Lecturer of YLL National University of Singapore, School of Medicine, Singapore. He is currently working as a consultant in Department of Diagnostic Radiology, KTP Hospital, Alexandra Health, Singapore. Department. Dr. Dinesh obtained his MBBS from India. He was trained and worked in radiology in Bangalore and Hyderabad. Later, he obtained Fellowship of Royal College of Radiologists, FRCR, from UK. He received further advanced specialist training in Singapore. He is also a teacher in National FRCR Training Program of Singapore. Dr. Dinesh Chinchure, please.
Good morning, everyone. Thank you, Chairperson, for the introduction, and thank you, the organizers, for inviting me here. Even from someone coming from India, it's a very huge sensory overload for me to be in Dhaka. It's a wonderful city, very vibrant, a lot of youngsters I see here around when I went around the city yesterday. So it's been a very good experience so far, and very nice conference. Very happy to be here with you. I have, as Chairperson told, I have two topics. One is the topic of bowel and mesenteric injuries and the trauma CT, and the second topic is about the MRI in the rectal cancer. How do we stage, and what's important for the surgeons? Let's start with something which is more probably what I think is in the local context is probably more important topic. And as I understand, I think I have another half an hour to 40 minutes for these two presentations. So let's start, and let's see how it goes, and we'll try to do justice to at least one topic, and then move on from there. So I'm from India, and I work in Singapore now. This place where I come from. So for the topic, I have few objectives to like what shall we do for this let's see the importance of bowel and mesenteric injuries in the trauma CT, and the talk is restricted to the blunt abdominal trauma. We are not really covering the penetrating abdominal trauma or other injuries, and we'll see why they are missed by the radiologist, and we'll see what are the significant injuries and what are the non-significant injuries, and what are the CT features of these injuries on the trauma CT, and we'll see what are the new techniques which will help us, any strategies, so that it will help us how not to miss these lesions on the trauma CT. Coming first to the trauma, it's a very big leading cause of death in the young patients less than 45 years, and fourth overall for all ages. And it becomes very important because these are all patients who are economically productive, and they are youngsters, so the society needs them, the nation needs them. So the trauma is socio-economically a very big importance to all these for the society. And amongst all the trauma, approximately 10% of the trauma-related deaths are related to abdominal trauma in East USA. I tried to get some local data before I came, and I came across this from the Ministry of Health, Bangladesh government's website. This is, as I say, this is if you can read here, it's the injury-related mortality rate per 100,000 population in adults, which was this data is from 2011 and 12, and you can see that there's there's quite a significant amount of road traffic accident patients who die, and it's quite amongst all the other traumas. So at this time, I just want to pause and gather the feedback from the audience. How many of, with a show of hands in the Bangladeshi, my friends, how many of you routinely encounter trauma in your practice? Is trauma very common in your radiology practice here, or? Yes, very common, I understand. And how often you do a whole body CT scan, or is it again very common, or it's restricted to a very bigger centers? How is it? It's common, yes, and you do the whole body trauma CT scan, so that's very nice to hear, because that's very important, especially because ultrasound may not be really so useful, and it may be falsely reassuring in many cases. So Coming to the topic, this bowel and mesenteric injuries account for almost 5% of this abdominal trauma on laparotomy. That's on laparotomy. And after spleen, liver and kidneys, if you call these are organs, these are the fourth most common injured organ. So if you imagine, like spleen, liver and kidneys we encounter quite often, but bowel and mesenteric injuries, we may not be really diagnosing them so often, but they are still common, and we should know why they are, I think why it's not missing, it's why is it important, why do we should image them, or why are these bowel and mesenteric injuries so important. So why and the sensitivity and specificity figures are going from 50 to 60% to almost over 90% now. So that's one of the reason. Then why is it important is the other is incidence of mortality increases with time to operative intervention. So it's very important for us that we detect these injuries early and diagnose them early so that the mortality decreases. So if we see this mortality especially due to hemorrhage, peritonitis and sepsis, and if you see that if you delay, the more you delay the diagnosis, the more chances of this patient having a higher mortality. So we cannot afford to delay or miss this diagnosis. Another reason why it's important is this very interesting paper from 2008 radiology. As per this study, 74% of patients with this surgically important bowel and mesenteric injuries did not have surgically important solid organ injuries. So we may not really have solid organ injuries on the CT scan, but still this patient may have a bowel and mesenteric injuries. So we should be looking for it, and we should not miss it. And the fourth cause for why they are important, because the conservative management is becoming very common in these trauma patients nowadays. The surgeon wants to delay or don't want to go in as quickly as possible. They want to give us non-surgical treatment the first, because there are papers or there is data from the literature in the trauma and emergency medicine that the conservative management may be better in many cases. So the surgeon or surgeon friends, they want to prefer if conservative management, then the onus is on us that we give a proper diagnosis. We tell them what are the severe injuries, what the non-severe injuries are there, give our input so they are more assured, and so the patient may not have a surgery and still get better with just a conservative management. Just got stuck. I think I need help here. The slides do not move. We'll see why do we miss. That's supposed to be why do we miss. There is some the system issue. Why do we miss is there are many causes like variation of the CT equipment and technique, because every hospital may not really have a advanced CT. Periphery may have a older CT. The level of training and expertise. Someone in the on-call, maybe a junior resident or someone who's coming during the daytime, maybe really experienced person. So that makes a difference. And unlike these or solid organ injuries, which are very clear cut, we see the signs very easily. The bowel and mesenteric injury is not a very straightforward. We'll come to it, and there are different signs, so that we have to use all these signs to make a diagnosis. So you have to we should know what are the utility of this individual and CT signs. And other thing is presence of other injuries on the scan may distract the observer. So if you look at a splenic laceration, then we may have a satisfaction of search, and we may stop there looking for the further things. So always on a trauma, if you look at one particular injury, then always keep looking for other injuries, because they may be there, which may be very important clinically. So this is the whole, how do we diagnose when the symptomatic, signs and clinical examination, ultrasound, just for in the fast scan to look for free fluid in the abdomen, or diagnostic lavage. These are all the signs, but they are not really useful for these injuries. So the most important is multidetector CT scan. So depending on the So what are the advantages of multi-slice CT scan? Is higher spatial resolution, faster image acquisition, improved radiation doses. Of course, may not be really big concern in the trauma, but still we should know that. And as I was telling earlier, the sensitivity and specificity figures are are in 90s now. Technique, depending on the place where you come from, generally this is what we do, around 100 ml of contrast with a power injector, around 3 to 5 ml per second injection rate, a strength of contrast around 350 milligram iodine per ml. And generally we need a large bore IV line, especially that's what we need to communicate with the emergency department physicians so that they are ready with the larger line when we need it. Oral contrast is not necessary in the acute setting because we don't have time for that. So, but in a follow-up scan, we may do it, and we typically need to do a multiphasic scan. So when we do a multiphasic scan, trauma angiogram is generally first scan we do is arterial phase scan of from something starting from the thorax and abdomen and pelvis, and then we do a portal venous phase imaging and delayed images when necessary. The one important thing is the radiologist should be available at the console because we need to tailor these examination depending on the patient need, and we should see where we need to image again, where we need a delayed images. So these are all important, and especially for radiologists, we need to interpret these images at dedicated workstations, not really using thinner images, use all the orthogonal planes or curved reformats if necessary, do further post-processing. We should not really be using hard copy images or just on the PACS workstations to diagnose these. We'll see what are the goal of imaging in bowel and mesenteric injuries is to distinguish what is a significant bowel and mesenteric injuries that require a surgical intervention, and then differentiate these injuries from those which can be managed non-surgically. May not be always possible, but that's where the goal of imaging is. Then we should know what is a significant bowel injury and what is a significant mesenteric injury. When we say a significant bowel injury, this is a pathological kind of definition which says either a complete tear in the bowel wall or an incomplete tear which involves a serosa and that extends to, but does not involve mucosa. So a complete tear is significant, a seromuscular tear is significant again, just a serosal tear is not a significant injury. The non-significant bowel injuries include just a bowel wall hematoma or tear limited to serosa. So next is significant mesenteric injuries. Significant mesenteric injuries are active mesenteric bleeding, disruption of the mesentery, mesenteric injury that is associated with bowel ischemia. These are all significant mesenteric injuries. An isolated mesenteric hematoma is considered a non-significant injuries, but it's fairly common to see in practice. This is for the residents here. When you see these kind of images, we should know the patient is in shock, hyperenhancing adrenals, shock bowel, something very flat IVC, reflux of contrast in the IVC and hepatic veins, which we see here. So when you see these kind of images, then we should know that in trauma cases, we should know which we are dealing with something very serious and may need to stop the scan or image early if necessary. We'll come to bowel injuries. The common locations of bowel injuries involve the areas where there is a fixed and moving bowel. That junction there is more common, but having said that, the bowel injuries can occur anywhere. So bowel injuries, CT findings of the bowel injuries. The first is bowel wall discontinuity, extraluminal contrast if oral contrast is administered, but we don't really do it, and extraluminal air. These are all significant or highly specific signs. I think because of some reason this animation is not playing. So we'll come into the bowel injuries, the specific signs, the bowel wall discontinuity, and these. We'll go one by one. They are all uncommon because they are very highly specific signs, but in clinical practice we may not really see this. This is some bowel here. Extraluminal contrast is not common because we don't really administer the contrast in the CT in an acute trauma CT scan, but differential diagnosis will be an intraperitoneal bladder rupture. We'll continue with the first talk because that's where it's important. We just started here. Extraluminal air, again highly specific for bowel perforation, but not seen commonly as we see in a routine practice as perforation of say inflammatory causes, but it's when you see it, it's very important. Most important, one of the take-home message for the residents especially is when you see a trauma CT scan, or for that matter any acute abdominal CT scan, always look the CT scan of the abdomen in lung windows, especially because it's very easy to miss a small amount of free air on the routine abdominal windows. So when you do a lung window, you can see this free air much better. So this is one of important. There are many times there are missed diagnosis because we don't really see this on a lung window. Just another scan, very difficult, very easy to miss here, but when you make it lung window, it's much easy. So when you see a free air, we always, the other say differential, will be rule out the other causes like peritoneal lavage has this patient undergone, if there is air from the chest which is entering into the abdomen, a bladder rupture or pseudo-pneumoperitoneum. Pseudo-pneumoperitoneum is air in the abdominal wall, something like this, which is because of the superficial injuries. It's very easy to diagnose this, will not really have a problem here. Coming next to the bowel injuries, the not so specific signs. The bowel wall thickening is the one which is very common to see in the practice, which is isolated findings such as just bowel wall contusion, which may not really require any treatment. But we should know that this bowel wall thickening is very common to see in CT scan, because falsely we see many times when a bowel loop is collapsed or bowel wall is, there is edematous bowel wall, hypoperfusion complex. Next, coming to the abnormal bowel wall enhancement is again quite common. It can be either increased or decreased enhancement. The increased enhancement is because of the bowel wall with a vascular injury. Hypoperfusion complex, there is the increased enhancement. Decreased or absent enhancement is in the ischemic bowel. We'll see some examples. This is bowel ischemia. We can see that this is a trauma case. This is a loop of bowel. It's not really transected, but you can see there is a bowel, like looks like a bowel which is continuous, but it's not enhancing at all. So there is a ischemic bowel because of the tear in the mesentery. Another different increased enhancement could be due to hypoperfusion complex, especially this is because the interstitial leakage of contrast, a shock bowel. So this is where we need to differentiate. One of the signs described is called as a Janus sign. This is named after one of the Greek Roman god. If you see a bowel loop which enhances, vividly, and then there is no enhancement at all, then we should suspect that this is something abnormal. We'll come to the few cases. This man was a driver of a lorry, had a RTA, is trapped in the lorry for 30 minutes. You can see that there is a hematoma. There is hematoma around the duodenum, some leakage of contrast, but no other injuries. This patient was managed conservatively, and this periduodenal hematoma is quite common. At presentation, this was the hematoma, and after a few days, 10 days later, you can see that hematoma is decreasing, just there is residual wall thickening. This elderly lady was playing with her grandchild, and the grandchild was jumping on her abdomen. Maybe she was on some anticoagulants, and now when she came with pain abdomen, she had a plain CT scan. It showed again a hematoma, huge hematoma, especially around the duodenum. On contrast images, there was no leak. Again, managed conservatively. Another couple of cases of paraduodenal hematoma. You can see that this is the injury with the active leak, surgically managed along with the IR colleagues. Another case, again periduodenal hematoma, conservatively managed in this case. This young man, a motorcyclist, came with RTA. We can see that there is a hematoma around the retroperitoneum, and there is thickened bowel loops in the if you can see here, in the jejunal loops are thickened, but on surgery the loops were just edematous, and there was no surgically important bowel injury. So sometimes just an isolated bowel wall thickening can be very tricky. We may say and we may communicate this with the surgeon, but may not always be clinically significant. This elderly man, drunk driving, abdomen hit the steering wall, and we see a perigastric hematoma around the stomach, and there is a hemoperitoneum, but managed conservatively again. But these are the all important things. We should keep looking for all these smaller details. Another middle-aged man, driver, and had RTA. We can see that this is loop of bowel which is thickened, and you see this enhancing as we come down. This is the next section, the lower section than this in actual images. We see this doesn't enhance. You can see this here, enhancement and no enhancement. If I zoom, you can see there is enhancing loop of bowel and it doesn't enhance. So this was a jejunal transection on surgery. Young man, a 40-year-old man with a cyclist hit by a lorry. You can see that these loops are thickened here, but importance of lung window again. See, there is a free air and there is a tear in the mesentery. This was a jejunal perforation because of the mesenteric injury and bowel injury. Young lady fell from height from 7th floor, hypotensive at presentation, what we see here is, I just adjusted the windows, so you can see that there is some there is free and mottled free lucencies in the right iliac fossa. This is because of the cecal perforation and fecal peritonitis. This patient also had a left main bronchus injury, liver injuries, and splenic injuries. She didn't really make it. Another man, pedestrian, hit by a car while crossing the road. We can see that there is a splenic injury, but splenic injury and active leak, this hemoperitoneum. Especially in these kind of cases, it's very easy to miss because we'll have satisfaction of search and we not really look further down. But these patients also had a bowel wall thickening in the middle abdomen on the left side. There was injury on the surgery. Young man, cyclist, hit by lorry, hypotensive in presentation. This patient had a catastrophic injury of aorta, which is aortic transection. There was a left hemothorax, and there was thickened bowel loops in the abdomen in the jejunum. And the most important thing was this patient had a free air. So on surgery, there was jejunal perforation. Coming to the mesenteric injuries, for this sake of talk, I have divided bowel and mesenteric injuries separately as a CT wise, but in practice we do really see that. This is just for the sake of discussion here. So the specific signs are extravasation of IV contrast, abrupt termination or bleeding of vessels or mesenteric hematoma. The less specific signs will be just a mesenteric hematoma or mesenteric stranding. We'll come to each one in detail. Mesenteric vasculature evaluation is always very difficult sometimes on the CT scan, but the way we can do is you use the coronal images. The important signs of mesenteric injuries are vascular bleeding, which is irregularity of the mesenteric vessel, abrupt termination of the mesenteric vessels. So these are all, and of course the mesenteric extravasation. If you see them, then suspect mesenteric injuries. So we can see that there is active bleeding here, and if you look carefully, these all mesenteric vessels look bleeded in appearance. Even in the absence of these, we should suspect a significant mesenteric injuries. Mesenteric hematoma itself is very specific sign, but it's not really always a very significant. It doesn't really always indicate a significant injury which requires surgery. So just if you looking at the mesenteric hematoma, you can mention in the report, but the surgeon may decide to follow up depending on how the patient is doing clinically. This man, motorcyclist, hit a side of vehicle and patient had a pain abdomen. We can see there is an injury to the mesentery here, mesenteric hematoma. The differential of this mesenteric increased density will be something like retractile mesenteritis, which is diffuse increase in the mesenteric fat density, but we'll have some small nodes with a halo around it, so that's how we differentiate. A ruptured gist, this is one of the cases we had which simulated a mesenteric injury. Then there are some common features which are common to both CT, bowel and mesenteric injuries. One is intra and retroperitoneal hematoma and abdominal wall injuries. As you have noticed that this is not really a straightforward diagnosis, just like a splenic injury or liver laceration or kidney injury. We have different signs and then we have to make a sense out of it. So we should know that what is the sensitivity and specificity of these various different signs. One which occur commonly may not really be so specific, but the one which are do not occur very commonly, like some mesenteric tear. You can see here, this is huge mesenteric tear here, and there is bowel wall thickening. At this point of time, the patient was doing well. The surgeon decided to manage conservatively, but 2 days later, the patient wasn't really recovering, and the repeat CT was done. So that's the value of having a repeat CT scan in these cases. And when you do a repeat CT scan, we can give oral contrast because we want to evaluate the bowel better. You can see that there is persistent bowel wall thickening. The patient wasn't really doing well, and this bowel loop was abnormal. There was perforation, although there was no leak of contrast on surgery. Old 75-year-old man, lorry driver, lorry collision. The first CT at presentation just showed a mesenteric hematoma or just mesenteric stranding. Small bowel looked thickened, but didn't really look very bad. Didn't really look that bad. But the most critical thing in this case was this small amount of free air was missed. Very difficult to see this, but this was very significant, and this patient came back again 13 hours later. The repeat CT scan shows there is a bowel perforation here. Even without a lung window, we can make out that there is a bowel perforation, and this patient was managed surgically, a confirmed perforation and on surgery. This is again zoomed view. Pediatric cases are not much different, but they just have a different mechanism of injuries like lab bed injuries, bicycle handle bar injuries, and child abuse, which you should not forget. Then coming to the pointer is not coming. So you can see that this is involved here on the left side. So again another case here, which is the involvement of the circumferential resection margin along with lesion, a focal bony lesion in the right femoral head, suspicious for metastasis. So there's different grades of extramural spread. T4 is an involvement of either visceral peritoneum, which is called T4A is visceral peritoneal involvement, or involvement of the adjacent organs like prostate, bladder, uterus, or seminal vesicle is called T4B. So identifying peritoneal reflection is usually we use axial or sagittal images. You can see this is a thin T2 hypointense line, which is a peritoneum, and you can see that this tumor is going above the peritoneum and is involving the visceral peritoneum. So it's a T4A stage. So another case, you can see this is peritoneal lining, the tumor is gone above, and this is involving the peritoneal lining. T4B is involvement of the adjacent organs, like in this case there is bladder involvement, so there is huge tumor here, there is bladder which is involved, there is a component of tumor within the bladder itself. Another case, bladder involvement from the right side, there is bladder involvement and there is fistula between the tumor and the bladder. In this case the prostate is involved. Involvement of the seminal vesicles, you can see there how asymmetric they are. Involvement of the uterus has gone into the endometrial cavity. Tumor which has gone into the pelvic side wall with deposits in the extramesorectal planes. Low rectal tumors are important, especially because we need to see the sphincteric involvement in these cases, and they are very well seen on the MR. You can see on the right side it's gone all the way beyond into the sphincter. You can differentiate sphincter signal intensity on the left, but you don't really see it on the right. And again another case of sphincter involvement. Then it's gone all the way to the pelvic side wall. And there is perforation of the tumor, and there is abscess into the ischianal and inorectal ischianal fossa. So there are different surgical options for the rectal tumors, like either you do a standard low anterior resection, or for an intersphincteric resection where the external sphincter is preserved, or the more drastic surgery will be APR or abdominal pelvic resection, where the whole sphincter complex and there is a permanent colostomy, whole sphincter complex is taken along with the tumor. I will skip this. Nodal assessment is again sometimes can be controversial or even on MR, but there are different techniques which are coming up. Not only we use the routine T1 and T2. Template reporting is very important. So to conclude and to take home message is MR helps the surgeons in obtaining a negative surgical resection margin. That's very important because that has a very good improved survival chances. Not only survival, but quality of life is good. Surgical planning, it helps surgical planning is because we identify the mesorectal fascia and the sphincter complex involvement, and of course the MRI has a role in assessing the response to treatment and detection of the recurrent disease. So I think within short time I've tried to cover these both topics. Thank you very much for your kind attention.
Thank you very much, Dr. Dinesh.